I'm Mark Williams, one of the emergency department consultants. In this session we're going to look at mental health. The reason we have a session on mental health is because it's a common ED presentation that you'll almost certainly see in your time with it. It's quite often complex and mixed with other problems. You'll see a lot of mental health presentations combined with alcohol, substance misuse, toxicology, and also physical health problems. Remember, suicide does have an annual incidence of 1 in 10,000 people and accounts for about 1% of all deaths. Locally we see about 20 to 30 patients per day in the emergency department with self-harm and or mental health problems. Do also remember that patients with serious mental illness also get physical health problems, and they have a lot lower life expectancy than the rest of the population. Various examples of presentations you'll see surrounding mental health, not only the ones that just concern mental health conditions by themselves, such as acute psychotic episodes, manic episodes, deliberate self-harm. You'll also quite commonly see people with patients with mental health conditions will present with overdoses, and also this quality of these, such as low GCS, arrhythmias. We also see problems related to drug use and substance misuse, such as drug-induced psychosis, and also a mixture of alcohol dependence and mental health problems. Let's look at how you approach seeing a patient with mental health problems in the emergency department. So you've left the induction, and the first patient you go to pick up and click on nerve centre has presented with an overdose, say. To assess these patients you need to use a combined approach, so you need to think not only physical health and doing a primary assessment A, B, C, D, E, but you also need to do a primary mental health assessment. The equivalent for this in mental health terms is AEOI, which stands for agitation, environment, objects and intent, which we'll go through in more detail. Primary psychiatry assessment first. This starts before you go into the room. Check the reason for attendance on nerve centre, and also previous attendance there. Also look at the alert. This is to check that there isn't any safety issues with the patient and previous violence and aggression. Patients who present with mental health conditions in the emergency department have slightly separate paperwork known as the Blue Book, which is completed by the nurses. Read this before you go in to see the patient. It's quite thick, but all the relevant information you'll need before seeing them is contained in the first 3 pages. Start doing your primary assessment. This starts prior to you walking in the room and may involve you observing the patient from a distance, so you can assess the level of agitation of the patient. Think, is the environment safe for you and the patient? There are special rooms designed for mental health and agitated patients in the department. Do see whether the patient has been searched or asked whether he's got medications on them, as they sometimes will take further overdose in the department, and also think have they got any razor blades on them. Also do be wary that sharp bins are out of the room if the patient is high risk. First thing you want to assess when you speak to the patient is, how are they now? Are they still actively suicidal? Do they want to leave the department? Remember your safety. I think I drew this cartoon after teaching a course with a load of psychiatrists, and what is really evident is that sort of A&E doctors, we tend to like to get very close to our patients, almost cuddle them, when a psychiatrist would be standing the other side of the room next to the exit and ready to get out if he deemed there was a risk to himself. So now you've completed your primary psychiatry assessment. If you feel it's safe to continue to assess the patient's physical health, you can carry on and do that now. If not, go and get senior help. Physical health assessment, do an ABCDE. Other sort of tests and treatment will depend on the presentation. Please only do blood as indicated, ECG as required if, for instance, they've taken an overdose that could affect the heart. For toxicology presentations, you do need to look at ToxBase. It's available on all the department computers, and password is available for our use. Do need to print that out and do read them. Certain drugs will have a sequelae in overdose later down the line, even for a patient that looks well when you see them. We get a lot of people asking for CT brain before they'll come and see a patient with a mental health presentation. Don't do this unless there's a clear indication such as a head injury, and do discuss with our seniors before requesting. One word of warning is for older patients who present with what could be mental health presentations. Do need to check that there isn't a delirium going on or other physical cause of their presentation. Do start a workup for this. And the older patients with mental health conditions quite often need ongoing combined care, and the best place for this is usually with our geriatrician colleagues, and consider admission to AFU, EFU. Once you've gone through the physical health aspects, you may want to go back and do a further assessment psychiatry wise. It may help if the patient has self-harm to think of slippers. Just a mnemonic that stands for suicidal thoughts. When you see them, do consider the lethality of the overdose or self-harm. It's worth considering that this should be assessed with both what the patient perceives and the actual harm the substance could have caused, for example. Do ask them their intent now, and also think protective factors and adverse factors such as employment, family, and otherwise. We've historically asked about a lot of demographic factors. It is worth asking these, but doesn't give you a greater amount of information going forward in risk stratifying them, both yourselves and our mental health colleagues. So as part of your psychiatric assessment, you want to reconfirm the history taken in the blue booklet and expand on any salience points if required. It's also worth you remembering there is a thing called the mental state examination, which I'm sure you were taught at medical school. It does really help when you're referring these patients on to the mental health team. It's a bit like an ECG is to a cardiologist. Don't use sort of fancy terminology in this, you'll probably get it wrong and confuse not only yourself but also the mental health team. One way I remember how to do a mental health assessment is from our Chem Learning, which is always send mail through the post office, which stands for appearance, speech, memory, thoughts, perception and orientation. Put it together and consider the presentation is psychiatric or physical health or both, and think up a management plan from this going forward, and then discuss with a senior. I'm going to go in some specific areas you may have difficulties with in the area of mental health patients in the ED. The first one is the use of restraint.
Billy, can you hear me? Billy, can you hear me? Can we just try and just roll him onto his back slightly? Is that possible?
Bit too violent for a minute. See if he calms down. Then we'll try roll him onto his back.
Billy, can you hear me? If we just...
Okay guys, what we're going to try rolling, yeah?
Okay.
James, we're going to try if we just hold on his head.
Alright, Billy.
As we roll him,
Okay.
just roll his head with us,
Right,
okay?
we'll just get some oxygen on Billy. Would somebody mind getting me some lorazepam, please? Aaron, would you get me some lorazepam, please? 4 milligrams in total?
Yeah.
1 milligram per mil?
You've only got 2 helpers, you've got Aaron and Anya and Amy.
Okay, thank you, Anya. No problems. Alright, Billy.
Show that nice big card over his face.
Yeah.
Turn his head to the side.
Yeah. Billy, I'm just going to put this oxygen on your mouth, alright?
Doctor, if you just take control of his head,
Yeah,
we're going to roll him towards me.
Okay.
James, if you stay as you are, just roll with his legs, okay?
Yeah, no problem.
Towards me on 3.
Alright, Billy, you're in a safe place. We're just going to roll you onto your back, alright, my love? Okay.
Yes.
Okay, that's better. Is that a bit more comfortable?
No ED consultants were seriously harmed in making that video, which was done as part of teaching. It is, however, very, very tiring being restrained. Just talk around restraint a bit more now. It's not something you should be doing by yourself. You need to get a senior involved. It also needs nursing staff present. We're very lucky to have security in the department, but if somebody needs restraining, that needs at least 3 of them. And do try de-escalation first. It does require a lot of teamwork and good communication between the team, and you do need to avoid putting the patient face down. That can be dangerous, and if safety allows, keep it to the minimum time possible. Restraint is really there as a last resort to keep us and the patient safe. Tranquillisation. This is required in some patients, especially when they're extremely agitated, and also if they're requiring sedation. Sometimes preferable to give some drugs to calm them down before they need restraint. This is not something you should be doing by yourself as a junior, and a senior needs to be involved. Patients must be in a suitable environment and monitored. This is normally in the emergency room. We use drugs as per the national guidance in the ED, and do consider an oral dose first if the patient will take this and their level of agitation allows this. We'll now look at assessment of the capacity. There is an area in the Blue Book that gives some basic guidance on this. It also gives an area for you to document the discussions you had around your capacity assessment of the patient. This does need to be done for all patients with mental health presentations, and there was also an area to record reassessment of capacity in the book. Let's look at how you assess capacity, and this is in the context of someone wanting to leave the emergency department after self-harm or refusing treatment. You should assume capacity until you prove it otherwise, and remember it's a two-stage test. Firstly, the patient to have capacity must be suffering from a disturbance of mind, and that disturbance of mind must be impairing the decision-making process for the treatment decision in question. So capacity is decision specific, so that's usually in the ED around wanting to refuse treatment or wanting to leave. You next then need to assess the following. Does the patient understand the information, and can they retain the information? In someone who's delirious, severely intoxicated from either drugs or alcohol, it's likely that they'll fail these conditions and not have capacity, and that's fairly straightforward. Communicating that decision is Usually fairly straightforward to assess, but do remember you need to get independent translator if somebody's first language is not English. Don't rely on relatives. The one area where we sometimes struggle to make an assessment as far as capacity goes is whether the patient can use or weigh up that information in coming to a decision. An approach you can take to assessing this and how to deal with this patient is ask them why they want to leave. There may be reasons like they need to get home because their child is home alone, they've got pets at home, and you sometimes can resolve these matters. It also gives you a better understanding of why the patient's wanting to leave. Do recheck the patient understands the consequences of not staying for treatment. And do go on then to ask them how they've come to that decision, what they've considered. I would also then go on to ask them about drugs and alcohol in recent hours, so you can assess whether that's affecting their decision making. After that, you do need to go on and ask more mental health questions, such as how they're feeling recently. Ask them about stresses, strains, and emotional turmoil, because that can affect decision making. And also go and ask them about recent GP attendances around depression, stress, strain, mental health conditions, and whether they've had any contact with mental health teams. With all this, you should be able to assess whether there is any serious mental illness affecting them weighing up the information they've been given to come to a decision. Do after this, and if a patient still wants to leave, go and get senior review and their opinion on whether they feel the patient has capacity. Just one thing to add, I think if you get a patient who's refusing to speak with you, refusing to interact with you, I think it is reasonable in the context of self-harm to assume there is no capacity. The team are based at the Leicester Royal Infirmary and quite often based on EDU. They're an all-age service. Their phone number's in the blue booklet, and they cover the emergency department 24/7. Please do refer to them when the patient is fit for mental health assessment. This is not when the patient is medically fit. Please let me know of any issues with this. Please also do bear in mind that it is very difficult to do a mental health assessment if somebody's still very intoxicated with alcohol. They'll either see the patient in the ED or ask them to send them to EDU on the EDU mental health pathway. You can also contact them at other times for advice or previous records on a case-by-case basis. They do have access to RIO, which contains all the mental health records, and this can be an invaluable source of information, especially on very unwell patients. This slide just shows the EDU mental health pathway. Please do read through it, noting the inclusion-exclusion criteria, and also circled shows the phone number for the mental health triage team. If there's no reply to that number, it usually means they're in the middle of an assessment of a patient. Please call them back later, and it's sometimes worth ringing EDU to see if they're available. If you're getting recurrent problems with this, pathway must be signed prior to the patient going down to EDU by the doctor in charge. I'll now talk about toxicology in the emergency department. This is a very common presentation to the emergency department. Patients present with this either due to self-harm, overdoses can be accidental, especially seen in toothache for some reason, and we also see people who have problems with substance misuse and become very ill as a result of Approach to patient who's taken overdose or has a toxidrome is to do a primary assessment first, and A, B, C, D, E. You do need to look on ToxBase to see the toxic effects of the substance they've taken once you have a history of what they have taken. Do print out those sheets. Do assess the patient fully, and do be aware of the timings of when they've taken various substances. If it's an early presentation, the patient could become very sick very quickly, or there could be a delayed toxic effects of the substance, such as you sometimes see with metformin. Paracetamol is probably the most common toxidrome we see. There is a specific pathway for this, which includes continuation of treatment on EDU. We do continue the care of the vast majority of patients who have taken an overdose on EDU if there's an indication to need continued treatment or a continued period of observation. The EDU pathway is shown here. Please have a good read of this. Note the inclusion and exclusion criteria on the pathway. EDU is not designed to have patients who need cardiac monitoring on it, and please be wary of patients who have got a high probability of deterioration prior to considering admission to EDU. You do need to fill in a plan there, and also fill in the check boxes. Pathway must be signed off by the emergency physician in charge prior to referring them to EDU by phoning EDU up. You can use this pathway in conjunction also with a mental health pathway. For paracetamol overdose patients, please use the separate paracetamol EDU pathway. That's the end of this induction session. Thank you for listening, and I hope you found this useful. I look forward to working with you in the emergency department.